So diving right into our first question for today's webinar, how will we know if this is working? What are the metrics and how do we get to them?
I think the way we know it's working, where we're achieving health equity, is when we begin to see closures in the gaps between with those disparities gaps that I talked about earlier. As we've gotten to the getting practice and building the muscle of disaggregating data and understanding how the our performance metrics show, are experienced in different populations, you first see that gap, and then as you start to put interventions in place, we can go back to that data and see whether the interventions we're putting in place are actually closing the gap. I bring in the underserved population, the BIPOC population, getting their numbers and outcomes closer to the majority. So that's the way that we start to see that people experience healthcare differently, and the data starts to show it. Society feels different about it. That's how we know it's working.
Yeah, I completely agree with everything that Dr. Nyoku said, and I think we have to be careful here because, as she was describing earlier in her remarks, is that there are many pockets in the U.S. where disadvantaged or subgroups that are experiencing disparities in outcomes, the percent of the population is actually quite small. And when you take it down to a specific health system or specific practice, it becomes even smaller. And so you may not have enough power in your data to know if a program is working in a specific setting. And so it's super important that we join hands across health systems, across states, and try to tackle the problem top down using interventions that are known to work, and then measuring in bigger and bigger populations so that we can actually have power in the data that shows us whether something is working. And the things that are really important to us are for each of the subgroups that we identify, how many of the patients are actually receiving the interventions that are intended to drive those disparities down. So how many of those patients can we get activated into those interventions? How many of them can we retain in the programs? What is their satisfaction with the programs? How are they engaging with the interventions that we're putting in place? And then making sure that our data is not, that we're collecting the data and analyzing it such that we understand what it is about our interventions that are affecting the patient behaviors as well as the provider behaviors. And so it's not just about, it's not just about creating those subgroups and looking at what the outcomes are, but actually knowing what is and isn't working, because we won't get it right the first time. And so you have to have what we would typically call, in a health setting or even in Wildflower setting, a continuous learning environment. So as you know, if I provide transportation to these people, can they get to their visits? Or if I'm surveying them more often for depression and anxiety, do I capture more of them and can I get them the access to the care that they need? And so it's super important that we're monitoring both the patient behaviors and the provider behaviors. Is the provider listening in a way that is effective? Meaning, are they receiving the information that they're getting from the patient and responding to it? And then finally, on the back end of all of that is obviously, we need to measure the health and economic outcomes. That really gives us a measure as to whether or not we're driving down those disparities. But there's a whole bunch of steps along the way. And really, if we keep our information and our policies, procedures, our programs siloed, that it blocks our ability to succeed, because you won't ever be able to scale. You won't be able to know whether something is working, and then you can't scale it. So I know I probably went outside the bounds of the question, but I think it's really important here to understand that that we have to work together.
I actually wanted to add something, if I may, and that's exactly the point that you're making, because as we're doing this work, the partnership of the community that you're trying to serve is absolutely critical. So if we're focusing only on data, as the point was made, it can get very cold and dry. But this is about feelings and this is about connection. And so the community you're trying to serve must be a part of the intervention you're trying to put in place. Nothing about me without me. Have a conversation and say, hey, we see that we are not serving you as well as we want to, what would be helpful? Because that way you're not, applying whatever it is we think is right, which history and experience has already shown us we don't get right. So part of how we know that it's working is when we get feedback from the community that it is in fact working, that they are feeling different about the care that we're delivering to them because we're doing the solutions and interventions in partnership. So yeah, I really thank you for calling that, and I really wanted to put an exclamation point on that.
Actually, you were jogging my mind here, because going back to something that you said when you were describing the approach that you're taking within your own health system is, it's super important to, and I know I'm reiterating something that Dr. Nyoku has already said, but understand your patient population from a socio-demographic perspective. And what we really try to do is survey that population, understand for each subgroup what their needs are from a social cultural perspective, as well as from a language perspective, sexuality perspective, and then match our digital interventions and our human services hiring to best meet the needs of those patients. And so, as she was describing, it is not a thing that you build that is going to solve this problem. You have to have the people that are local to the people that you're servicing, to join hands with them and to provide the support that they need to improve outcomes.